Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. Nowadays, many academic centers add on ultrasound of the lung to the curriculum for medical students, and it has been recommended that any GP, a general practitioner, and ER resident and ultrasound tech, any modality and specialty, should be familiar with the ultrasound of the lung. We have to remember that the ultrasound has two enemies, air and bone, or calcification. In those situations, sound cannot propagate. So the ultrasound of the lung can scan and check any structure from the skin up to the pleura. Beyond that, sound doesn't propagate and scatter, and we create a pattern that we call the dirty shadow, and we can see when we scan on the lung or any structure including abdomen, GI. When we scan and there is a gas, we see scattering or dirty shadow that sound cannot propagate and doesn't give us any information. In fact, the ultrasound of the lung has a very important feature, and that is artifact, that we use those artifacts for detecting those important pathology of the lung, including pneumothorax, pleurisy, pulmonary edema, pneumonia, and interstitial edema, or some of the respiratory syndrome. And sometime in COVID, it can help us to detect and diagnose many situations. For that reason, I am going first to start with anatomy, then we go with the normal pattern of the, or normal finding of the lung in ultrasound, and finally we go to those pathologies that's very important and critical for the lung. As we know, we have on the chest wall first skin, subcutaneous tissue, then we have intercostal layer of the intercostal muscles, then we have endothorax fascia, and finally we have pleura. Pleura has two layers, two layers, parietal and visceral. Parietal connect to the chest wall, and visceral connect to the parenchyma of the lung. And between them we have pleural cavity, and at the inferior part of the chest we have diaphragm that connect to the chest wall and create a sharp angle between diaphragm and chest wall. We called it costophrenic angle, and that area we called it costophrenic recess. In those situations that we have free fluid, the first spot that collected fluid is in this recess or angle. Beside of those structure, in some other spot we can see any extra structure, including serratus in axilla and posterior of the chest wall, and pectoralis muscles in anterior. So just be familiar with those structures, especially when you scan and looking for any pathology at this level. And we have to remember that those vessel and nerve, intercostal artery and vein and nerve, travel through the groove inferior border of the ribs. As I mentioned, the ultrasound cannot pass through to the lung. So in those situations that we have localized pathology in the lung, we can make our study more attentive and focus in those situations. For that reason, in those patients that they have some extra modality images, especially in hospital setting like the chest x-ray or CT scan, it can help us to go targeted ultrasound of the lung, in special when we see any pathology. For that reason, I'm just explain shortly about the chest X-ray and CT scan. Then we go for the ultrasound of the lung. As you can see here, the classic chest X-ray is PA, or posterior anterior. Chest of the patient is toward the plate of the film, and the X-ray tube is posterior to the chest, posterior of the chest. And we can see those structure very easy: shadow of the heart, trachea, and costodiaphragmatic or costophrenic angle, and those rib and structure, and pulmonary artery, and bronchus. Here just I mentioned that posterior part of the ribs curving and moving toward lateral or outside, and anterior part, those red line, as you can see here, is anterior part of the ribs and move midline the same way. And I have to mention here there is a two-way we do chest X-ray: PA and AP, anterior posterior and posterior anterior. The classic is PA, but in those situations cannot the patient stand, and especially in bedside or portable, we do AP, that we put the film on the back of the patient, and the tube of the X-ray is anterior to the chest. The main differences between AP and PA is that in AP, the size of the heart shadow become bigger and lung smaller, and in PA, vice versa, that in PA more accurate than the AP in those evaluating of the size, and some other structure, especially trachea in the PA, is more prominent. Here we have a chest X-ray of neonate. You can see those structure and markers. And here we have two very common chest X-ray that we can see. This patient has cardiomegaly and cage ball mitral valve, as you can see here. And this patient has the pacemaker, dual chambers, one electrode at the right ventricle, one electrode in the right atrium. So be familiar with those structure when you see on the chest X-ray. Here we have a CT scan, coronal view. Those structure we can see this cross section, short axis, that we can see in different level. We can move it, and we see those structure. Lung is dark, those vessels are bright, and other structure we can see any other uh, bright structure in the lung field is abnormal. Now let's go for the ultrasound of the lung. First, our probe. Generally, we can use any type of the probe, including linear, collinear, or phased array, or echo probe. But the best way for ultrasound of the lung is collinear. In those situations that we want to see better the up to the pleural, we can use linear because we can use very high frequency. But in those situations that we need deep, especially for pleurisy and any other pathology in the lung, consolidation or pneumonia, it's better we use collinear or phased array. As I mentioned before, one of the most important fundamental principle for ultrasound of the lung is artifacts. In other words, just only artifacts that create in ultrasound help us to diagnose most of the important pathology in the lung. So for that reason, we have to set up in a specific way if we use phase array, because as you know, phase array or echo probe, usually we use harmonic and we use compounding. In that situation, when we use a lung, if we have set up in our machine, it's better we use setup in the lung. We use select setup for the scanning lung, or if we don't have it, we can do many important optimizing image. First of all, we have to take the harmonic off. We make it zero for compounding, and all those other features that we make our image clean and more smooth, we have to put them down or eliminate for scanning the lung, because we want to have the highest resolution for the artifacts. That is the general point. The frequency we use it between, usually the best is 3.5 to 5 megahertz, but again is depending of body habitus and what is our depth of the study, how much we can go depth. Based on that, we have to be flexible. Another important parameter that we have to keep in our mind in ultrasound of the lung is pulmonary capillary hemorrhage. That in the animal study, it has been shown the ultrasound can cause pulmonary capillary hemorrhage, but in the human, we don't have too much information. But as a general rules, for that reason, it's better we keep our mechanical index less than 0.7. The best is 0.5, but we can add on up to the 0.7, and is again is dependent of the time of our scanning. Generally, we shouldn't hold too much our probe in those, especially neonate, too long in any specific spot. When we need it, just a few seconds, get image and freeze it. In that time, the ultrasound is off. There is not any sound, so we decrease the timing of exposure to the ultrasound. The protocol for the lung has been different in many academic centers. The general common protocol is a 12 spot. In each side of the chest, 6 spots. We divide it to 3 areas: anterior, axillary, and posterior. And based on that, we divide each area to upper and lower, or superior inferior part. So each side 6 spot, total become 12 spot we scanning. But in some other situation, maybe we need more. Some places they use 16 spot, some places use 18 spot, but generally 12 spot is general and acceptable protocol for scanning. How we do the scanning for that situation? We at the anterior, we put at mid clavicle at 2 spots, one of them superior between second and third intercostal space, and another is below the nipple at this level. And then we go for the mid axillary. Here we have axillary, anterior axillary line, posterior axillary line. At mid axillary we go upper part and lower part, and for posterior we ask for the lateral surface and posterior. Is better patient in the lateral hold his or her arm up, put on their head or put it up, and for posterior is better patient sit and wrap around arm like hugging himself or herself, so expand and move the scapula outside. We can have enough room for scanning upper part and lower part. The line of our scanning, the holding probe and orientation of the probe is sagittal, means we put the marker toward the head, and this way. In those situations that we have pathology inside of the lung, we better do transverse too. Just we put it between intercostal space and following and surveying that that area from the medial to the lateral, and from the same way in the lateral space and posterior space. But for those important pathology related to the artifact, pneumothorax, pulmonary edema, interstitial edema, and those other situations like COVID, just sagittal view will be enough. But if we have any specific pathology, it's better we do sagittal and transverse. On transverse, marker will be toward the right of the patient. Both sides, doesn't matter, right and left. But for the sagittal, probe marker will be toward the head. And when we scanning and document, we have to remember that that area, we have to scan and survey that area, not one spot. We just survey that area, left and right, medial and lateral. Then we will find if there is not any pathology, then for documentation, one in the mid clavicle, and we annotate exactly where we are and what orientation of the probe is. Usually, when we see sagittal, we see those ribs that it show us it is sagittal. But generally, we have to annotate location and orientation and the side of the chest, right, left, upper, anterior, lower anterior, and so on. For the lateral surface, we can go mid-axillary line, upper part, and lower part. For the lower part, we have to see the diaphragm and liver and lung all together, that we checking the costophrenic recessor angle. So that is our lower part for the axillary. For posterior, the same way. In the inferior part, we have to see the diaphragm and part of the liver and lung. That will be our shot for the each side. As I mentioned, the ultrasound of the lung can only create image from the skin to the pleura. Anything above the pleura will be artifact, and those artifacts that shortly I'm going to talk about that are important for the evaluation pathology of the lung. Here you can see we have a normal linear probe that we put it around this area. Here below the skin we see those specific pattern of the muscle. Here pectoralis muscle, major and minor, and then below that we can see intercostal muscles, three layer, that is not very clear on this one. And final structure that normally we can see is pleura as a hyper echo line, curving line, depending where we are scanning, is sometimes this way, but most of the time curving concave, and sliding with breathing, moving back and forth, up and down. This is a normal ultrasound of the chest wall up to the pleura. And we have other structure we can see here. Here we have rib that has hyperecho surface, curve shape, hyperecho, and posterior shadow. If our footprint of probe is big enough, we can see another uh, rib here, that it can give us a face of the frog, or sometimes they called it bat. It's not a big deal. The most important on this feature we can see is sliding of the uh, plural, that we called it long sliding or sliding sign. This is very important finding, and it's due to moving of the visceral pleural over the parietal pleura. That is very important feature in normal lung in ultrasound. This feature can be seen much better in linear probe because high frequency and resolution is very higher. We can decrease depth, but in Kelvinier and sector or echo, we can see it, just we have to optimize it, but those sliding is not very clear on the other two. Linear is much better. Here you can see sliding. We cannot differentiate between parietal and visceral, but as long as we can see hyperecho pleural moving back and forth with the breath, this is represent that we have untouched visceral pleural that is sliding over the parietal pleural. Later we talk about that one of the finding in pneumothorax is we losing at that specific spot that pleural has been ruptured. But it's not only in the pneumothorax, in other situation we can see. Later we talk about that. With this feature, we can do it M mode and find all those structure. When we do M mode on the level of the pleural, here we have a specific pattern in normal situation. We have first those layer that give us a horizontal layer up to the pleura. Here, the top one, it looks like a C on the horizon when you watch the uh, sea and wave is show. Those hyperecho line belong to those trabeculation and fascia in the muzzle between the intercostal and all of them. It create some this pattern, we called it C part, and beyond the pleural, due to the sliding of the pleural or lung, it creates some kind of the sandpaper on the M mode that we called it shore part or seashore. This is a normal pattern. Top one linear fixed C part, and shore part is below the pleural. So this is the hyperecho line. Here is our pleural, and below that is the artifact of the M mode beyond the pleural and movement of the pleural. So we call it seashore. Seashore or sandy beach is a normal M mode of that part of the lung. If we don't have this sliding and we put at that level cursor, it doesn't give us this shore pattern, so it become all horizontal layer hyperecho, between them hypoecho. It looks like a barcode. We called it barcode sign or stratosphere sign. That it's one of the classic finding in pneumothorax is this one, but it's not specific for the pneumothorax. In other situation we can see it. Later we are going to talk about that. If we find the spot that the pleural has been ruptured and put our cursor there, with breathing in and breathing out patient respiration, we can detect normal that the pleural come to the field of the cursor, and when disappear, it give us barcode pattern. This one is very specific, more than just barcode, for detecting pneumothorax. This is more characteristic and specific for pneumothorax compared to the just barcode sign. Later we talk about that. Anything beyond the pleural we do on the ultrasound will be artifacts, that most of them belong to the propagation artifact, and those important artifacts are very useful for detecting and diagnosis of lung pathology. Now let's go see what those normal artifacts we can see and what those are abnormal. Another normal finding in 2D of ultrasound of the lung is feature and characteristic features of the diaphragm. When we scan lower part, especially when we have close to the diaphragm on the right side and left side. Below the diaphragm, we have liver on the right side and spleen on the left side. The feature of the diaphragm in the ultrasound is very characteristic and very clear, and it looks like a curving hyperecho smooth thick line, as you can see here. This is our diaphragm, and here is abdominal mode. So here our marker on the left side, here is superior or lung, and here inferior or caudal, and is liver. On this one is echo mode, marker on the right side. So here is the cephalic side or marker side and lung, and this one is caudal part, or here is a liver, as you can see. Echo mode and abdominal mode. Just when you're scanning, know what is the orientation of your probe. Marker always should be toward the head, and uh, where is the marker on the monitor, or which mode we are scanning. Based on that, you know orientation of your structure. So the diaphragm is very clear. We can detect very easy when we see it. In the normal situation, when the person respire, inhale or exhale, when inhale, the lung come down and come cover up the diaphragm and part of the even liver on the right side or spleen on the left side. This feature we called it lung curtain or curtain sign. Means that in that area above the diaphragm we have normal lung and feeling, and in inhale it expand and come cover the diaphragm and liver. Above the diaphragm, as I mentioned, we have just air. Those alveolar just has air, and we don't expect to see anything about the diaphragm except dirty shadow. Like this, they are dirty shadow, or maximum we will maybe sometime we see B line. On this case, you can see B line here. This one B line, or two actually B line. Here one B line, here many B line, 1, 2, 3, 4. Anyway, about the diaphragm, in normal situation, we shouldn't see any structure except dirty shadow or a B line. In some situation, normal situation, due to mirror image artifact, we can see some tissue of whatever is beyond, below the diaphragm, see above the diaphragm, as you can see here. This is our diaphragm and this is our liver. We see this structure of the liver, exactly mirror image of some part of the liver represent about the diaphragm. That is a normal finding. And on the left side, if we have spleen, maybe we see some echogenicity about the diaphragm in, and we have to not confuse with pathology in the lung. When we scan on the lateral, especially when we do lateral, I'm pointing to medial at the lower part, left or right. We normally we use the liver or spleen, and it sound can travel, and since on the lateral we point to the midline, at that level we sound can go travel and hit the surface of vertebra, and we can see vertebra body here, 1, 2, 3, 4. About the cross section of the diaphragm and the vertebra, we shouldn't see any structure. Mean from this spot above, we shouldn't see any structure. If we see here, for example, vertebra, it means that sound can pass through this level and this level too, and create the image of the vertebra about this level. So we have fluid in this area, or consolidation or mass or anything that lets sound pass through this region and create image from that what the structure here is vertebra at the alignment of the sound beam. Here we can see we have diaphragm. Here we have vertebra, and above that still we can see vertebra. To this feature that we can see vertebra above the diaphragm, we called it spine sign and represent we have some pathology process here. It can be fluid like this, or some consolidation or mass or tumor or anything that let sound pass through that region and create those images. Yeah, we're done with the first section of the lung ultrasound in normal situation. In next section, we are going to talk about all pathology and technique and how we differentiated those situations that belong to the master group. Up to the next time. Have a wonderful time.